Good day. My name is Imelda Williams. I am going to give you feedback on the practice bank that I gave you. I trust that you have got your opinion form at hand so that you can go through your responses as I give feedback. Case one was a patient who was in a car accident and now complains of CSpine tenderness. I'm going to do for this case. So if we look at our reversible, anti-reversible line, you can see that you see one, this is C2, that there is a fracture, and the fracture is in the inferior corner of the anterior vertebral body. And that is typical appearance of a flexion teardrop fracture. There's also some prevertebral soft tissue swelling as well. If we look at the alignment, and the anterior vertebral line is more or less intact, but there is a slight step in the posterior vertebral line if we come from between C2 and C3. If you remember from the presentation that although flexion teardrop fracture is actually one of the more severe fractures, which can have neurological consequences for the patient. So for this patient, there is the alignment has been slightly affected, the bone has a fracture, and then also there is pre-vertebral soft tissue swelling as well. Overall comment is that there is a flexion teardrop fracture due to vertebral body at the inferior corner, and there's also pre-cervical soft tissue swelling, pre-vertebral soft tissue swelling. So case two, we have a patient who was in a car accident. The airbag bag was deployed, and there's diffuse tendons over the cervical spine. If we look at the AP view and spinous cases, this looks fairly as it's in the middle central. And it doesn't appear as if there's major drops in the anterior vertebral height. On the lateral view, if we look at the alignment, there are the steps in the line, some anterior, posterior, the spinal laminar line, and the spinous process is also seen quite okay. This one is an open knife as well. And if we look at the open knife, the distances are more or less equal from the dense to the lateral mass. And then the lateral mass is obviously running through two lines on both sides. So this case was a normal case. There's nothing here that indicates that there is a fracture or a dislocation. So for case 3, I think there's another image as well. So this is of the upper cervical spine, so that doesn't capture quite well on the other image. You can see that this patient had a harness on. So the upper vertebra is quite fine, they don't have this anything there. Image. And here you can see that just you can just see that can do it a little bit like that. Yeah. It's good. So it's quite clear that there is a step forward of that's C1, 2, 3, 4, 5, 6 of C6 on C7. So that type of forward, if you look at the percentage that the slippage, it looks like it is almost bordering on 50%, 40 to 50%. So this is a bilateral facet dislocation of C6 on C7 with approximately 50% forward placement of the vertebral body. And this makes it an unstable fracture. So overall then, your alignment, of course, has been affected this space has been affected, so the joint is affected. Doesn't appear as if there's any structures. There's lots of artifacts, so we can't really see the bone structures, but the overall common then is a bilateral fracture dislocation of C6 on C7. And case 4 is you see this is the spine of an elderly patient, and if the patient had an unobserved fall and has neck pain. So the main thing, let me just zoom in. So the main thing that we can see here is that there is a step from C1 to C2. So there's a C1, C2 dislocation, or the Atlanta axial dislocation. There's, of course, also mild degenerative disease of the spine. So these are all degenerative changes, chronic changes. But the main somatic indication that we can see here is this C1 on C2 dislocation. So the alignment has been affected, the bone is affected, and of course also the joint spaces because of the degenerative disease. So the overall common thing is Atlanta axial dislocation, or you can say C1, C2 dislocation. And in the final case, the patient whose head was forced against the windscreen and has a very tender neck. I want to start with the open mouth view. So on this image, if you look at the distance from the lateral part of the dens to the lateral mass, there's a big discrepancy from right to left. We can see it's much more a widened space there. If we look at how the lateral masses of C1 aligns with C2, on the left side seems okay, but on the right side we can see that the lateral masses of C1 overhang C2. It might appear as if there could be something going on at the base of the neck, but this is just the muck effect. So there isn't a fracture at the base of the neck. You maybe thought that would be the case. On the lateral view, and then the zoom in a bit, we can see there's a fracture of the posterior arc of C1. So we have a C1 fracture with malalignment of C1 and C2 lateral masses, and this is of course in keeping with a Jefferson fracture. So the alignment is affected, the bone is affected, and of course the cartilage and joint is also affected. So that is the end of the 5 cases. If you have any questions, please feel free to contact me. Thank you.